7:40 right now. We'll go to the phone line.
And we want to welcome back Paul Seegert. He is the managing partner at PCS Advisors. And this morning he is here to talk to us, to break it down for us about President Biden's domestic health agenda, which is currently stalled in the Senate. Good morning, Paul.
Good morning. How are you today?
Doing well. So break this down for us. What, according to this and a story in Axios, they said Biden was trying to jumpstart pieces of his domestic health agenda. What's he trying to do?
Well, there's a few things. One is he talked about capping the out-of-pocket cost for insulin, which is always a popular thing to talk about. And that one is a little bit interesting to me because that already had been accomplished during the prior administration. In his administration, when they came in, they put it on hold with an executive order. So he's really just reinstating something there that had already been done, which was to cap the out-of-pocket costs that a consumer would pay when they get their insulin filled. So it's a good thing to do, but it's really kind of putting it back to a place that it had already been. And then the second thing is looking at Medicare and talking about getting Medicare where it can negotiate its own drug prices. And then the third one is making the subsidies that expanded Medicaid during the COVID rescue legislation permanent, where you have a situation right now where no one in the country pays more than 8.5% of their income if they go to an exchange to get health care. And, both of those are I think, interesting, too. They're popular things to talk about, but there's a lot more to it, and there's an interesting story behind each one. When you look at the Medicaid expansion, a lot of those subsidies, you could have a couple that's making $200,000 a year with no dependence on their plan, and they would get a subsidy today. So it's actually taken people off of employer plans and put them onto government plans. So in many of those cases, we weren't extending coverage to someone who didn't have it. We were spending money at the government level that, you could argue maybe wasn't well spent. And then the Medicare drug negotiation thing is something that's been discussed time and time again, and it usually doesn't get very far. And also, there were some executive orders when Biden came in that stopped some progress that had been made there. So it'll be interesting to see how this all plays out. I'm not expecting real big changes.
Well, when you talk about somebody making $200,000 a year allowed to do the Affordable Care Act and only paying 8%, now that's really happening, I guess.
Yeah, that's happening. It's funded through the end of this year. So what they would like to do is make that permanent, which is, often what we see. They'll make something temporary with the intent that they can make it permanent later. And it adds a significant cost. We pay, when the government does this, we spend about $20,000 per person that we put on health care, which is higher than when that same couple that's making $200,000, if they were to get their coverage through their employer, the coverage would be better, generally speaking, and meaning their out-of-pocket risk is often lower. It's accepted by more providers, that kind of thing, and the cost to have them on would be significantly less than when the government does it. It's just not the most efficient way to do it.
Now, which one of these proposals is likely to pass? The most likely to pass? Yeah,
the insulin, I think, can be pretty easily done. That's something that he could do at his level. Medicare price negotiations, that always faces pretty strong headwinds from the drug industry. They're very powerful. And making the subsidies permanent, I think that could be a tough one as well. That would be a very big spend on the part of the government. So I think the insulin, we can expect to see insulin out-of-pocket costs capped, and the other two, I have less than 50% confidence that they'll happen.
Now, obviously, even I noticed that had already been done back during the Trump administration, and But whatever is approved, would any of them really improve the quality of health care in the U.S.?
Here's the problem. What they end up talking about, I mean, it's a perfect question. They end up talking about capping out-of-pocket costs for insulin, and they don't talk about the fact that our system, when we buy insulin, 60% of the cost that we pay is waste. It's unnecessary fees that are added on by middle players in the system that do not make the insulin, do not wholesale the insulin, do not retail the insulin. Pharmacy benefit managers in this country represent 60% of the total cost that we pay for insulin. So they're leaving that waste alone. I mean, it's just evidence that lobbying is still effective. And then they kind of pander to the consumer about capping out-of-pocket costs. We wouldn't have to worry about those out-of-pocket costs if we addressed the real waste. So it won't really have a significant impact in a positive way on our health care. What would have a really positive impact is if we could address the fact that 30, 40, 50, 60% of what we pay for lots of prescriptions in this country is waste, and it's unnecessary. And that's what we really need to address. If we did that, a lot of these other conversations would be unnecessary.
And Paul, don't we here in the United States pay more for our prescriptions than anybody else?
Way more. I mean, we represent 70, 80% of the global profits for the drug business.
What would be best case scenario to get us down to a livable, amount that we pay for our medications?
Yeah, there's three things that we could do. Number one, eliminate that waste that I talked about. Rebates represent or make up a lot of that waste. So we should eliminate that practice where they're allowed to add all these unnecessary costs to our drugs. We should the second thing I would do is allow for fair cash pricing in the system. We actually don't have that today. So we really do not have a free market when it comes to prescription drugs. If you're a pharmacy and you take insurance, you're not allowed to determine your own fair cash price for that same drug. It's dictated to you by the insurance company, which certainly does not sound like a free market, and it isn't. It wildly inflates the cost of drugs. And then we need to, a little more obscure but still important, we need to change some of the rules around orphan drugs and how we allow and the kind of subsidies we provide for that, and the length of time that they can sell these drugs without competition before generics come into the market and so on. If we were to do those three things, which really wouldn't be that hard, we could cut the cost of drugs in this country in half. I say it wouldn't be that hard, but it's really very difficult because you have such powerful lobbying forces against it.
What throws me off as I'm listening to this is it sounds like it's easy to identify where the waste is by that middleman that's causing the cost to go up. And I've heard, I'm not a diabetic yet, I may be someday, but that, you can go to Canada and buy the same meds, the same box, the same everything cheaper. I know you can go to Mexico and get stuff in the same box, the same everything, and it's cheaper. Right. Why are we deliberately robbing our own people and saying it's okay?
Right. Yeah, we do not. We allow it, and it's really crazy. You can have the same, and we also allow the system to increase prices every 6 months. We just went through a round of drug price increases, and I think the average was about 6.6% in 6 months. So you have, if you look at Humira, the most commonly prescribed specialty drug in this country, that drug was $60,000 a year to have one person on that drug 6 months ago. Now it's $64,200. It went up 7% in 6 months, and it's a poster child of what's wrong with what we're doing. There are no generics for that drug in this country, and yet if you go over to Europe, the drug itself is cheaper, and they have a few generics that are available that are way cheaper. So really what it boils down to is we're not going to get the change we need out of Washington, because when you track where this industry gives money, it's with precision to the right people to prevent any real change. Unfortunately, at least to this point. And it really doesn't, I'm not picking on one side or the other. It doesn't matter who's in charge. we just generally don't see a lot of change. We'll see a good press event. We'll see somebody talk about it, the president talk about it at the State of the Union. And then when you dig into it, they're not really addressing the problem. They're looking at some of the symptoms maybe that the consumers see, like, hey, we're going to make sure your copay is not too big on insulin. Let's talk about why insulin's overpriced and how we can actually fix it. And that's what we really need to turn the conversation to, and we just haven't done that in a real significant way.
And Paul, is Humira one of those drugs that you call an orphan drug?
It's not an orphan drug, but it is a specialty drug, so it's in that second most expensive category of drugs.
What is an orphan drug? Say that again.
Yeah, an orphan drug is, originally the thought was we wanted to create incentives for drug manufacturers to create drugs that would treat a disease that not very many people had. So we create some extra financial incentives, some tax breaks, and longer periods of exclusivity, and so on, to encourage them to create drugs for health conditions that were serious, but maybe they only affect 100,000 people in the world. And so what's happened is drug companies have started to focus in a lot of their R&D, their research and development, energy and resources into those areas, and then they'll create a drug. Maybe it only treats 100,000 people, but maybe they charge $100,000 a month to have you on the drug. So it's this huge. That turns into really big dollars, and so there's been an unintended consequence there where that's become a huge focus because they really don't have any controls, any significant controls on the profiteering that can occur there.
Well, let me ask you this, and then we'll wrap this up. But what about the cards that they tell people to go get, like GoodRx or one of those? Do those help at all?
Sure, they help. They kind of will open your eyes as a consumer when you pull that app up on your phone and you see that the same drug can cost wildly different amounts within 5 miles at a handful of different pharmacies. It kind of opens your eyes to how crazy the system is, and it does help. But again, it's not going to a really significant level of change that's going to fix the industry, but it's helping you navigate it the way it is more efficiently. So I do encourage people to use them, but the real solution is going to be doing some of these changes and fundamental changes that allow for a free market to exist, where these pharmacies, pharmacy benefit managers, the whole system actually competes for your business on cost. That's what we need to get to.
Is it easy to track lobbyists for these companies and who they give money to?
Yeah, it's not that hard to look it up. I mean, some of it's tough to track, but there's other dollars are not that hard to track. If you just log onto the internet and do some searches on where the money is getting donated from Big Pharma, you're going to find out it's on both sides of the aisle, and it kind of tracks with who's in charge. If one party's in charge, they might get more of the money, and when the other party's in charge, it shifts pretty quickly to keep things static.
Huh. Looks like calling those folks out might help a little bit.
Yeah, it seems like a good idea. I don't see why someone doesn't go run for office and say, look at this. I'm not going to take this money, and we're going to help solve this problem.
Yeah.
But I think they get up there and they get pretty addicted to it pretty quickly.
I can imagine.
We want to thank Paul Seegert, Managing Partner, PCS Advisors. That is a health benefits consulting firm with 35 partner offices across the nation. Paul, where can our listeners find out more about your business?
Well, you can go to PCSadvisors.com. We spell it with an ERS at the end, and every day we get up and go to work to help employers navigate their way through this. I think they are going to be the ones that fix healthcare for America because they can't just print more money for something that's overpriced.
All right, Paul Seegert, thank you so much.
Thanks for having me.
You bet.